All right, Rachel, take it away.
Good evening, everybody. Welcome to our ninth virtual shadowing session, Medical Spotlight with PAs in Primary Care. If you have any questions regarding our program, please email us at virtualshadowing@gmail.com or DM us on Instagram at virtualshadowing. This session will be posted on our YouTube channel, Pre-Health Virtual Shadowing. So if this could work. So after this session, we will have upcoming topics such as diversity in medicine, a specialty spotlight in emergency medicine pediatrics, and acute and critical care. So be sure to tune in on Tuesdays at 7 p.m. Central Standard Time. The team working behind virtual shadowing is composed of Reagan, Shayon, Taylor, Elena, myself, Rachel, Aniruth, Miriam, and our two fantastic physicians, Dr. Fowler and Dr. Marchetti. And I'm sure you all know Dr. Marchetti, but now he's officially part of our team. Dr. Fowler, Dr. Marchetti, do you have any words to say to everyone tonight?
Well, good evening, everyone, and welcome to Virtual Shadowing. We're now barely 3 months into this effort, and as of this evening, almost 11,500 of you had signed up to come join us and be part of a real-time opportunity to visit the practice of medicine in all sorts of different specialties that we can share literally with the world. Over 500 universities are represented. We have some exciting people coming up. We will delay momentarily introducing our guests for the evening. In a couple of weeks, we will have one of the members of our admissions committee talk about diversity in medicine. The following week, we'll have another member of our admissions committee talking about pediatrics and pediatric emergency medicine. We'll have another member of the admissions committee talking about acute and critical care. So what I'm saying is that we, the working group, are trying to make this effort be something that is clearly recognized by institutions that if we can't get the shadowing in person, then let's get it virtually. I do want to bring up something you will see in your email in the next couple of weeks. We're probably going to ask you for $1. The reason is it's costing us a few $1,000 to have a MailChimp account and the Zoom account for as many people. We're okay, but we thought it might be worthwhile and useful if you wouldn't mind supporting it a little bit. We will keep track of the money raised. We'll put it on the website in terms of the revenue raised and the expenses that we have, so you'll know exactly where the money's going. Sorry to bring up money, but I just did want you to know that we want to keep doing this, and if you'll support it, we'll keep doing it too. I want to also make one intro comment. I started medical school almost 50 years ago, and the medical school I went to, the Medical College of Georgia, I went to an experimental program that for the first year of my medical school, I went to school with physician assistant students and with nursing students. We in my class were trained from the beginning that medicine is a team approach. Ladies and gentlemen, joining us tonight, if you think otherwise, you're getting into the wrong field. It ain't just the doctors and the nurses and the physician's assistants and the nursing practitioners and the technicians and the secretaries. It's all of us working together as a team. It takes the team. Without the team, it won't work. My entire career, I've worked side by side with physician assistants. Indeed, at Parkland Memorial Hospital, I'll ask Dr. Marchetti in a moment to comment. We work beside some of the finest advanced practice practitioners I have ever known. What matters to be great in medicine is a relentless interest in understanding and remembering and applying your field. So, Dr. Marchetti, quick comments about the PAs that we work with?
Yeah, I can't really follow that up with too much more. Absolutely a team effort. The advanced practice providers include both physician assistants and nurse practitioners at our institution, and they take care of some of the sickest patients right alongside me, a lot of times independently and autonomously. And I learn probably as much from them as they think that they might learn from me. And we couldn't do this job without them. This night is for those of you who are going into, pre-PA or a PA. And so cheers to you.
Thank you, Brandon. That was wonderful. Rachel, let me turn back to you now to introduce our guests.
All right, thank you. Before that, let me just explain about Zoom and our session quickly to our new members or our members in general. We will have two Q&A sessions or sections. So if you have any question, please put it in the chat as we go along. Our working group will be compiling a list of them so we can ask our speakers today those questions during the designated times. We are taking questions from both the Zoom chat and the YouTube Live. If you have any questions regarding the assessment, we will cover that at the very end, so please don't ask questions about that right now. And moving on, let's hear about our speakers. So we have first Crystal Lopez and also Tu Fortner. Crystal is a physician assistant with experience in internal and family medicine. She has a special interest in behavioral and mental health. She has an immense caring heart as she donates her time to the Agape Clinic, a nonprofit organization that gives unconditional care to the community in downtown Dallas. She has 2 rescue dogs with her husband in East Dallas. Tu is a physician assistant working in a private women's health clinic, women's outpatient clinic, and she is not only a patient, well-spoken woman, she is a strong leader, educating her patients and her coworkers about women's health and also a role of a physician assistant in medicine. Now, my short spiel is not nearly enough to describe these 2 incredible women we have here today, so I would like them to each introduce themselves and tell us more about their journeys. First, let's have Crystal introduce herself.
Thanks, Rachel. That was really great. Hi, everyone. I'm Crystal, and like Rachel said, I'm a PA. So a little bit about me. I went to the University of Texas at Austin, and I wanted to study the brain. That's all I knew I wanted to do was study the brain. So I pursued neurobiology. And, you know, I had to figure out what I was going to do with that degree, what it was going to make my living off of. So I tried research because I thought, hey, you study the brain, you do research. And I hated it. I did not like being in a lab. I did not like spending hours and hours on a experiment and then not getting any immediate results. So that I knew that, you know, research wasn't for me. I really wanted to do something that helped others and gave me a little bit more of immediate gratification, as much as I hate to say. So what else do you do with a degree in neurobiology? I decided then I was going to go to medical school because it was going to let me to help people and, you know, continue to study the brain. So I went on this medical school path. I was actually pre-med. I was, you know, studying for my MCATs. I was going to apply to MD school or DO school, hadn't decided yet. But I knew I needed clinical experience. And so then I became a scribe in the emergency department. And that actually changed my life because that was where I found out what a PA actually was. You know, I got to see what they were doing. Most of them were doing a lot of the same clinical services as physicians. So they were diagnosing, treating, ordering labs, imaging, prescribing medications. And so that was really cool. That was really interesting to me. And so as I got to know them more, they told me their training was pretty much modeled after physician education, and that they were practicing in any healthcare setting and nearly all the specialties. So, and a lot of them too had this job in the emergency department, but they were also doing other things like running marathons, or they were, you know, working at free clinics, or they just had other things going on in their life that a lot of the doctors didn't seem to have time to do. So I really liked that aspect. And so then I decided to become a PA. Some of the other things that really weighed on me when I was discovering what a PA was the flexibility. They were able to, you know, they were trained as general providers, but they were able to go into different fields. So I knew a PA who had worked in family med for a while and then transitioned into the emergency department. So that was really cool to me because I still didn't know exactly what I wanted to go study in medicine, but I knew I wanted to study medicine. So that was a really cool thing. And then the cost of medical school. So I paid for school on my own with the help of loans. And so, you know, 4 years of debt versus 2 years of debt was a really big deciding factor for me. So then, you know, that was kind of the still the deal for me. So then I applied to NAU, which is Northern Arizona University in Phoenix. I ended up there because my husband actually traveled for his job. And so we moved to Phoenix. and I wanted to be close to home. So I applied to Phoenix or Northern Arizona, got in, and graduated August of 2017. And then 2 weeks later, I completed my PANCE, which is our boards. And then in 2018, I got my first job. So that was about a 5-month break between graduating, taking my boards, and then actually getting a job. So I just wanted to put that out there because you're not on anybody's timeline but your own. And I know I was kind of freaked out in the beginning about not having a job immediately after school, but I got to go to Spain and I traveled a lot. So I think that time off was really worth it. So I got my first job in internal medicine in January 2018, and that was a really good learning experience for me. It was my very, very first job ever in my supervising position. I was his first PA, so that was a big learning experience for both of us. And unfortunately, it didn't work out. There was some issues, and it didn't work out. Let's just say that. So then 6 months later, I get my first job in family medicine. So now I'm on my second job in June 2018, and I loved it. It was in an underserved area, underserved community, actually in the community I grew up in, which is Oak Cliff, part of Dallas. I think I saw somebody on the chat was actually from Oak Cliff. So anyways, did that for about 1.5 years, and then I needed something closer to home. I live actually in East Dallas, so it was quite a drive. And I just moved to a different clinic, and I was still practicing family medicine. So that was October 2019, and I did that up until March when the pandemic hit, and then I've been on furlough ever since. But I kind of wanted to just highlight that I've had 3 jobs since I've graduated school, and I was really kind of worried that it was going to look bad on my end, but I just wanted to put it out there for the students that you're, like I said, you're not on anybody's timeline but your own, and it's your own story, and how you get there, we're all gonna do something different. So, take the time off. Don't be afraid to take the time off. I know a lot of the working group on here has taken a gap year, which I think is amazing. So, anyways, I will give it back to you, Rachel.
Thank you, Crystal. That was a fantastic story, and thank you for telling us your journey. Now let's hear about Tu's journey. Tu?
Hi, everyone. So I am Tu. So my journey, I kind of started from a little bit earlier, but essentially my parents really wanted me to pursue medicine. So I don't know if there's a lot of people out there that fell on that same track. But that was kind of the route that I went in. And I think over time, that's kind of what I became most comfortable with. As I got into college, I think I was really just only used to the idea of either nursing or MD route. And so when I got into college, I actually just joined a bunch of pre-health groups and found that pre-PA was kind of the place where I felt most appealing. So agreeing with some of the things that Crystal talked about with flexibility, kind of always having a team there, and then just that ability to kind of spend more time with the patient, not kind of get caught in the nitty gritty, and then just meeting the different PAs that I've seen. I just felt like I could connect with them more. So I kind of continued to get involved during undergrad. So I actually was vice president of the Pre-PA Society at UTD. If anyone is from there, any fellow comments. And then I just kind of continued to grow my interest from there. I actually worked as a medical assistant during undergrad to get my patient education hours. And then I also took a gap year in between undergrad and PA school to work as an EMT. So just to kind of give myself a break since I'd been doing school nonstop. I started PA school in 2016, I think, at UT Southwestern. So you want to go to the next slide. And so with kind of the way that school was, we did didactic the first year. I actually met my husband during that year. He is not in medicine at all. So I actually met him outside of medicine. And I got engaged during clinical year. So that was kind of my big life change. And then I graduated. I did my PANCE exam and I passed. And then I actually found a job about 3 months after graduation. I also took a similar funcation like Crystal, just because in between school and work, that's pretty much the only time you're going to ever have in order to travel or do anything that you want to do. And I think my story, I guess, will kind of go towards the fact that you can still have a life in PA school. A lot of people got married. We had classmates who got pregnant during school. And so still possible to kind of have a life during PA school and kind of still move forward with your life plan. But yeah, that's my story. So back to you, Rachel.
Thank you. Well, that was a fantastic journey. Thank you for sharing. Now we both heard about these incredible women's journeys. Now let's figure out what's their role in medicine. Tu, can you tell me what is a physician assistant?
Yeah, so you kind of have like the textbook definition of a PA on the screen, but basically physician assistants are medical professionals that work in collaboration with the supervising physician to kind of offer care to patients. So we are an extension of our supervising physician, and we can help fill in those gaps in their clinics. So, we see patients, we'll diagnose illnesses, we order labs, imaging, we interpret those labs and images, we can treat, manage, prescribe. So we can kind of do the full gamut. I think the bigger difference towards the end is that we don't do surgery on our own. We can certainly assist and do procedures, but we're not just in the OR on our own. So we can kind of fill in any healthcare gaps in all the different specialties, just throughout all the different communities.
Cool. So Tu, you mentioned some differences. Can you go into some differences between PA and nurse practitioner?
Yeah, so nurse practitioners and physician assistants are both called advanced practice practitioners. We used to be called mid-level, so they actually changed that. So we kind of practice on the same scope of medicine. PAs kind of follow the school of medicine in terms of training. So we're kind of trained earlier in terms of kind of diagnosing a patient, thinking about a differential diagnosis early on. NPs tend to follow the school of nursing. So they still get that bit of medicine, but it's a little bit more on the patient care side. So they kind of focus more on like their ADLs or acts of daily living, kind of helping with the more nitty gritty with the patient. The other thing is that NPs can open clinics on their own and kind of practice on their own. Physician assistants have to work with a supervising physician in order to kind of practice and have any prescriptive authority.
All right, cool. So you mentioned that PAs can't really do surgery. Is there any other difference between PAs and like MDs and DOs that you can think of?
Yeah, so we kind of have similar training in that we are kind of set up with the didactic and the clinical year, but it kind of truncated a lot. So we kind of fast track through a lot of different topics. So MDs, they get to go a little bit more in depth in their specialty, and then they'll have their residency. So they are kind of like the cream of the crop, the head honcho in their specialty. PAs are kind of trained in general medicine. Most of the programs focus on primary care. That way, as you kind of start looking for a job, as you start working, you can kind of fill in whatever specialty or whatever calling you need to. So that's kind of the biggest difference. Certainly name recognition. A lot of people know MDs, they know doctors. Physician assistant is still a fairly new profession in comparison to an MD or nursing. So a lot of times, a lot of people still don't know who you are. They may confuse you for the medical assistant or for the nurse, or they might think that you are also a doctor. So still a lot of education needs to be done, but I think those are kind of the main differences.
All right. Now, Crystal, how do you see the role of physician assistants evolving in the future? Crystal, you're muted. So you'll have to unmute.
There we go. Thank you. So I think we're already evolving in a sense. I know we talked about this last night. There has recently been laws that passed that PAs can now volunteer without having a supervising physician, which wasn't a thing before. And so that's really cool. I think the more PAs we have, the more we're coming together to advocate, kind of have nurse practitioners have been. And so I think in the future, we're going to have a little bit more autonomy, which means we can do more things without actually having a supervising physician. So I think that's one of the ways it's going to change, like opening our own clinics even may become a thing. But I really like having a supervising physician, so I hope that that's one aspect of the field that doesn't change.
All right. So you guys both mentioned supervising physician. Can you go into more detail too? Can you tell us what a supervising physician is?
Yeah, so a supervising physician is someone who kind of delegates prescriptive authority, and their license is kind of tied to yours. So I mentioned earlier about you being an extension of your physician. So whatever you do, whatever treatment plans, however you manage patients, it kind of is connected to your supervising physician. So in the state of Texas, I think all 50 states, we're all required to have at least one supervising physician. You can have more depending on the location that you're practicing in. And you have to have a certain amount of contact with your supervising physician, whether it be directly or through phone or text. You always have to kind of have a line of communication open in case you need them. And then typically in terms of contact, I think the state of Texas requires a certain percentage of your medical charts to be reviewed by your supervising physician. That way they can kind of see the way you're kind of working through different patients and different cases and kind of how you're managing, and that's appropriate as well. So you kind of always have someone kind of checking your work or kind of supporting you in case you need anything. But there's something that you always kind of want to look out for when you're working, because most of us work closely, or we kind of have a close relationship, even if we don't see them or talk to them every day.
So how often would you say that you're communicating with your supervising physician?
So in my office, I actually see my physician every single day. We talk about any of our postpartum patients that are in the hospital, and I actually round on those patients and discharge them for her. So I talk to her pretty regularly. Even, earlier today, I had a complicated patient that I kind of went over, but typically it's pretty short interactions. I talk to her maybe about 5-10 minutes every day. If there's about any patient or anything overall. And then most of the time I'm kind of just on my own seeing patients in clinic, and then she's kind of on her side of clinic seeing patients.
All right. Crystal, would you say that your communication is with your supervising physicians at like any of your previous experiences are kind of the same? Are they different?
Yeah, so I've had 4 different supervising physicians in my short career. And they've all been a little bit different. So the first one I had he was an internal medicine MD, and I was his first PA. So there was a big learning difference there. He really wasn't sure how to utilize me as a PA. And so most of the time it was a lot of me explaining things that I could do, which you'll probably do for the rest of your career. But anyway, so that was one relationship. The second relationship I had with my supervising physician, he actually was never in the office. He was like halfway to retirement. So he was off doing his own thing, and we would talk by phone, but I hardly ever saw him. And then my third supervising physician is actually at the free clinic. And he is super, super busy. He's still working at Methodist. He's going overseas and doing in different countries and practicing medicine there. So I see him about once a month. But every time I see him, we have a really good relationship. We talk about cases. He's always available if I have any questions. I've got his phone number. We text. So that's a really collaborative relationship for just seeing him once a month and almost never seeing him in person. And then my most recent supervising physician, we actually work very closely together. We were in the same clinic. We had the same hours. Sometimes we had the same patient. And we would see each other in the hallways. We would talk before and after work. We would send messages. So it just depends on your setting and the provider that's your supervising physician. So it can vary from anybody.
All right. All right. So moving on, let's talk about some pros and cons of being a PA. Tu, can you cover some pros and cons?
Yeah, so I think we kind of touched on them a little bit earlier, but just going to go through them here. So schooling is a little bit faster. So most programs are about 24 to 30 months, depending on where you are, what state. There's no residency afterwards. Most of PAs can kind of just go into the field and kind of work directly and kind of learn any specialty specific things on the job. Versus, an MD where you're having to do additional residency and fellowship and everything afterwards. Definitely affordability. A lot of programs try their best to be more affordable for students, and then you're just there for a shorter amount of time. So I think that's really good. And then lateral mobility, I think both of us have talked about that. So having the ability to switch specialties and kind of move, and as you kind of want to experience things, I think a lot of PAs tend to move to different specialties after a couple of years in order to just kind of keep up with their knowledge and kind of whatever they're interested in. And as Chris was kind of discussed, it's been pretty easy most of the time. The other thing that's really nice is that your supervising physician or your hospital group typically takes care of all the nitty gritty. So they take care of your malpractice, they take care of your insurance and all that stuff. And so you typically just get to go to work and focus on your patients. So that's the really nice thing. And then in terms of some of the cons, I think those are kind of there. Less autonomy kind of depends on where you are and who your supervising physician is. So a lot of times that's where that advocacy part comes in. So being able to kind of tell them about what you can do, what you've been trained to do, and how you can help their clinic and their day-to-day. And then certainly we do get paid less than an MD. So.
All right. For our members, we actually have a PDF that we will post shortly in our Google Drive of some of the salaries of a PA that you can see. Thank you too for providing that. Moving on, let's learn about how to be a physician assistant, like the application and schooling. Crystal, can you take over on that?
Sure. So once you decide you want to become a PA or go to PA school, start looking into the individual PA programs because there's a little bit of different requirements for each program. So that's where you really want to start, looking at where the deadlines are is another big thing because those all vary also. But the nice thing about PA application process is the thing called CASPA, which is Essential Application Service for Physician Assistants. So many schools, so many PA programs use this this service. It's one website. You go and you put in all your information, your essays, your schoolwork, your transcripts. You'll put everything in, and then they'll review it, and then they send it to each individual PA program that you choose. It is a long process though, so as soon as it's open to students, then I would start applying, start putting in your information. You can work on it kind of one day at a time, but you really want to get it in and get it done as soon as possible because the earlier you apply, the better your chances are. There's a lot of fees involved also with application processes. So, CASPA, I can't remember exactly what the price is for everything, but I'm sure you can Google it. I know CASPA has a supplemental or a waiver, so you can apply for a waiver if you can't afford the fees. And then look at each individual program again and see if they have an additional application that they want you to fill out, which also comes with some more fees, unfortunately. But really, you want to look at the different schools. Most of them have different requirements based on letters of recommendation that they want, patient care hours, how many do you actually need? That can vary from school programs. And then I have the GRE listed on there too, because some schools want the GRE, but we were actually talking, there may be something called the PCAT or PACAT that's coming. It's a new graduate test that you would take to get into PA school. So be on the lookout for that, do your research on that, see if schools are requiring it or not. I just found out about that also, so. So yeah, and then while you're applying, you want to make sure you're gaining patient care hours. That's what PCE stands for there. So doing volunteer work, shadowing, working. I know too as an EMT, I worked as a scribe. I had some students in my class who were doing research work, and they were working with patients, so that counted towards their patient care hours. But really look at the program individually and see what's required.
All right. So let's talk about the PA school.
So yeah, once you get into PA school, you can celebrate a little bit, but then get right back to work because it's a really intense program. It's 24 to 30 months straight through, no breaks. I mean, you get like a day or two off here and there, but for the most part, there's no breaks. So you can't work. There's a lot of sacrifices that you make. I know I missed a lot of holidays, a lot of birthdays, a lot of big events. So just make sure you know what you're getting into when you're going in. But it's only 24 to 30 months, so you're buckled down for that time, and then it pays off in the end. So your first year, you're typically doing in-class lectures, group works. You also do your standardized patients. So these are paid, sometimes paid, but these are people who come in and know that they're getting an exam done by a student for learning purposes. So in PA school, we get that experience kind of before we even go out into doing our clinicals. So we go into clinicals a little bit more prepared. And then in your second year is when you do your clinical rotation. So that's 4 weeks going out into the clinics, going out into the community, doing your core primary care electives. So like family med, cardiology, I think cardiology, pediatrics is another one, surgery. And then you have your elective fields that you can choose. I did a pediatric cardiology rotation, which was really cool. And then I did a emergency psych rotation. That was really awesome too. So after those 4 weeks are done, then you go back to your classroom and you take an end of rotation exam. And those are meant to prepare you for the PANCE, which is your board exam. So they're exactly similar questions, just how to think about these questions, how to just really getting prepared for the test. And then you have your OSCEs, which is your, it's kind of your long exam, but with a patient. So kind of like your standardized patient. They give you a case, you go in, you do an exam, you take your history, and then you get graded on that. And I think we have two. Is that correct too? We had one, I think, at the end of the first year, and then again at the end of the second year.
Yeah, I think we had like a series where they did like a few cases, but they're all timed. I think for Southwestern, we did 15 minutes in with the patient and then 15 minutes to write a note. And then they would grade you on both. So the standardized patient actually grades you on how well they think you did, how competent and comfortable they felt. And then your faculty will grade you on your plan, your assessment, and all that. So, but I think one was kind of towards the end of didactic and the other one was in clinicals at some point.
Yeah, I just remember being really nervous about that. And then you also, at the end of your second year, you do a research project or a capstone project. So you take a clinical question and then you research it and you present it to your class. I actually did mine. I actually applied for a fellowship with physician assistant educators. And so I put a lesson plan together and then I presented that to my class. So it can really, in our program, it was really anything you wanted your presentation to be, but you do a research presentation at the end. So then once you're done with your second year, you can graduate with your master's and then you can sit for your boards, which is the PANCE. And then after that, you can also choose to do a postgraduate program, which is about a year long. Most of those postgraduate programs, or if you want to do a specialty like surgery or emergency medicine, I've seen some with plastic surgery. There's one in urology too, which is kind of random, but it's not necessary at all. You can go into any of these fields without having to do that postgraduate training. It's kind of like a PA residency, I guess you could call it. And then after you get your certification, you pass your PANCE, you have to recertify every 10 years. So it's not on the slide, but we did talk about, we wanted to mention that every 10 years, you have to sit again for your boards and keep your certification. And every 2 years, you have to get 100 hours of continuing medical education credits. So these are just conferences or journals or self-taught self-assessments, just stuff to keep you up to date with what's going on in the medical field. So that's the PANRE. So instead of the PANCE, you sit for the PANRE.
And then just a side note on that, for any future PAs or new PAs, most supervising positions or hospitals will actually give you an allowance for your CMEs. So definitely remember to ask about that, because you have to have CMEs in order to keep practicing. So most will actually pay some amount, or they'll pay for memberships to like TAPA, like our national or our state organization. So definitely something to kind of talk to whoever's hiring you at the time to kind of see if you can get that into your contract.
Yeah, they give you time off too for that to go to conferences. So
Oh, wow, that sounds awesome. Sorry, a quick interruption. I apologize. I made a mistake on the PowerPoint. There is a discrepancy about PA school. For the post, on this slide, it says 24 to 36 months. On the previous slide, it was supposed to be 24 to 36 months. PA schools can vary. So I will fix that before we post it on our Google Drive. Just wanted to make a quick announcement. But yeah, that sounds pretty awesome, that route. So let's hear about a field. Let's hear about Tu's field. Tu, take it away.
Okay, so as I kind of said earlier, I work in outpatient women's health. So I kind of included pictures of some things I see on the day-to-day basis, but I kind of started working right out of school. This is actually my first job. So I've been here for a year and a half, almost 2 years now. And so I've been kind of working with my supervising physician for a while. So I'll kind of move on to the next slide. So my day typically starts about 8 o'clock, 8:30. So I actually come in early to kind of look at any labs or imaging or any patient messages that I get sent. And then I start seeing patients at about 9 o'clock. That is kind of like the variety of patients that I'll see. So well women's problem visits. I see all of our OB patients for their first confirmation visit. So kind of educating them about what pregnancy is going to be like, answering all their questions. I talk about birth control, periods. We also do some procedures in the office. So I remove and place IUDs, Nexplanons, cysts. We'll do suture removals for some of our postpartum patients. Kind of just a little mix of things throughout the day. I typically end my day at 5 o'clock or 5:30. So I try not to take work home with me. So when it's time to go, if I can, I'm out the door. But before that, if there's any postpartum patients that are in the office, I'll actually round or just kind of go over them with my supervising physician. And then I'll see them the next day in the hospital. But otherwise, I'm not on call and I don't do any weekends or anything like that. So I am on like a strictly clinic schedule, which is very nice. Okay, so I have 2 case studies. I know everyone likes to have a little bit of more practical experience. So this case is a really common scenario that we typically see in our office. So you have this 48-year-old female patient coming in. She is a G4P4, so that means she's been pregnant 4 times and she's had 4 deliveries. She's coming in for heavier cycles. So slowly they've been increasing over the past year. Her cycles have moved from now about 4 days to now about 7 days. Her flow, or the amount of bleeding that she's having during that time, has gone from, I don't think I said, but basically at this point, she's kind of saturating a super tampon every hour to 2 hours. And then she's also passing, by her description, large baseball-sized clots. Which you have to take with a grain of salt because your patients use different words to describe things. But basically, in her eyes, she feels like she's bleeding pretty heavily. She says otherwise, though, her cycles are coming every single month. So they're still really, really regular. The other thing that she'll kind of mention, which I didn't put on here, is that she's getting a little bit less energy. She's getting a little bit more tired throughout the day. And every once in a while, she'll feel kind of like lightheaded or dizziness. So because this is like a problem visit, you kind of want to focus in on her problems. So we're not going to do a full big exam. We're going to kind of just focus in on her pelvic exam. So on her exam, you're assessing kind of, do you see anything at the vaginal canal, anything at the cervix? And then you'll do a bimanual. So you assess kind of the overall size of the uterus, kind of see, is she feeling any tenderness, anything in any particular area. And so you do that exam, you don't see anything. Also, all of her vitals are stable. So she's not, she doesn't have hypertension, she doesn't have fever, nothing crazy. And then no medical, no surgical history. So from our standpoint, relatively uncomplicated so far. So at this point, you're kind of thinking about what could you possibly have. So certainly thyroid abnormalities, fibroids are a really common one in older patients, thickened lining, so possibly malignancies. Certainly if she's approaching menopause, sometimes she can have some irregular cycles, and then any clotting disorders or anything like that, which typically less likely with her age if she's been having regular cycles for the past 20 plus years. So we do some labs. So the first big one, especially if she's been bleeding for a long time, is a blood count. So that's what CBC stands for. So we kind of make sure, is she anemic? Is she doing okay? This is just like a little snippet of the blood count. But from this, you can tell with the red blood cells, the hemoglobin, the hematocrit, she is anemic. So she has been bleeding for a while, and this blood work kind of shows that. And then the other thing we checked for her was her thyroid stimulating hormone, which is her TSH. That's one of the more common hormone imbalances that can impact her cycle, but hers is normal. So most likely that's not the cause. Sometimes for patients who aren't having regular cycles and they're kind of skipping a month or two, we'll also do a hormone evaluation. So that's estradiol and FSH, and that kind of helps us understand ovarian function. For her, because she's still having regular cycles, we didn't feel like it was going to give us any good information. So we did not check that, but if your patient was a little bit older, if you had some other stuff, you can check that as well. So that's kind of the information that it got us. Still not a ton of information. So we're going to do a sonogram to kind of see if there's anything that we can see inside the uterus with patients with varying BMIs. Sometimes you can't always get like a good assessment of the size of their uterus. So we need some imaging to get some measurements. So basically you take a look at the uterus, and on imaging, it's 8 by 4 by 5. So pretty normal. Anything under 10 is good. Her lining, or her endometrium, which is the lining of the uterus, is normal. So we know that there's not some intense thickness that's causing her to bleed so heavily. Ovaries are normal, and then we don't see any masses. So no fibroids, nothing abnormal that we need to go in and remove. So kind of thinking we're not really seeing anything. So at this point, we want to kind of take a little closer look at the lining of the endometrium. Sometimes we can't really see the cells or the pathology. So we do an endometrial biopsy. And so the biopsy is something we actually do in our office, and we take a sample of that lining. So we'll pass the device actually through the cervix, and you'll be able to kind of collect a couple of those cells and send them off to the lab. So for this specific patient, we didn't really see anything. So there wasn't any malignancy from the small sample that we took. So at this point, we're kind of feeling pretty good that there's not really anything malignant, anything that's kind of abnormal with this patient. So sometimes you don't really know why your patient is bleeding, and this patient was kind of one of those cases. So what you want to do is kind of figure out a treatment option for her, something to kind of help control the bleeding until she can kind of get to menopause, where then we don't have to worry about that anymore. So these are kind of some of the common options that we have for management. There are obviously other ones. These are just kind of the foremost common ones that we do in the office. The first one is tranexamic acid, or Lysteta, which is that first little picture. It's an anti-fibrinolytic, so it kind of helps stabilize the lining, stop the bleeding. It's more short-term, better for patients who are a little bit more compliant, because sometimes we'll give them enough to kind of self-treat as they need it. So that's an option. The other one would be the birth control pills, which would help regulate her cycle. It's more long-term, but it is something that she has to do every single day. And then the third option is the IUD, or the intrauterine devices. So we place those in the office. They're very great for bleeding control, and it's less work on the patient side. So once we place it, they don't really have to do anything, so we don't have to worry about them being compliant. And then depending on kind of what duration we think she may need this for, there are a couple different options. So the Skyla is about a 3-year IUD if she just wants something quick. Kylena and Mirena are about 5 years. the Lilet is 6. And so those are the hormonal IUDs that we have right now. There is a 10-year IUD, that's the Paragard. There's no hormones in that though, so it is not appropriate for this patient. It would not help her bleeding at all. And then the last option would be an ablation. So that's a procedure that we actually have to take to the operating, or take the patient to the operating room. And we actually kind of cauterize the lining of the uterus. And so that is kind of a better option for patients who are no longer wanting childbearing, since this will impact the ability for them to become pregnant or keep a pregnancy. So for this particular patient, we actually put her on some Lysteta until we could get her into the operating room or schedule her for an ablation. That was this patient. Certainly not everyone treats that way, but that's kind of what we did for this specific patient. And then the next one is one of the other really, really common visits that we have. So a ton of patients come in for birth control. That's a really big question. So this one's kind of like a standardized patient. She's 19 years old, coming in. She's a G0, P0, so she's never been pregnant, never given birth, normal BMI. And then she's coming in for birth control counseling because she kind of wants some better control of her cycles. So her cycles are typically pretty painful, heavy. Sometimes she actually has to miss days at school because she's feeling really uncomfortable from the cramping. She's not really sexually active, and she doesn't really have any other medical history. The main thing for her is that she's actually going to be going off to college soon, so she won't be able to follow up with you regularly. So this is kind of the next slide will kind of show you how I go through counseling patients on birth control. So that chart just kind of shows everything in general that you can do. A lot of my patients, I typically run a spiel where I kind of talk about all the various options that are available to them, and then kind of sensing what options they're more receptive to, then I'll kind of delve in and give them more information about that specific option. So I usually start by letting them know the pills you have to take every single day, the patches every single week, the NuvaRing is every single month, and then you have your depot that's every 3 months, and they have to come into the office for that. And then we have the arm implant, which is every 3 years, the IUDs, which, as we've talked about earlier, can range from 3 to 10. And then just kind of seeing how they react, whether it be like facial expressions or kind of what they tell me, I kind of go through that route. And so you kind of want to consider when you're also counseling your patients that you want to know how reliable are they with taking something every day or doing something regularly. If they need it for contraception, then you kind of want to talk to them about how to correctly dose or take their various birth control method. And then if they have access to a pharmacy, so if they have to go pick up something every month or every 3 months, depending on how you prescribe it, and then how good they are to follow up. So for this specific patient, we actually did the NuvaRing because she could not take a pill every single day. So I kind of talked to her about the NuvaRing, how to store it, how to place the device, when to remove it, and what happens if it suddenly gets pulled out. So the other important counseling point that I put in there is that hormonal birth control does not prevent against STDs. I actually have this question a lot. And so that is a big point to kind of talk to your patients about. It helps prevent pregnancy. It doesn't protect them from anything else that they may experience while they're sexually active. So condoms are still something that you want to continue to kind of endorse and educate them about. But I think that was that patient. So that was just kind of a quick overview of what we see in the office. Typically, I spend a lot more time with these patients and kind of answering all their questions. That's actually what I do a majority of my visits, because a lot of patients come in with questions. I use all the diagrams we have in the office. I have a mini uterus that I bring around. So a lot of time with patient education. So that kind of leads me to my next point about staying involved.
Sorry.
No, you're good. And kind of staying up to date on what's going on with your profession. So I am a part of these organizations, and then I kind of just wanted to introduce them to anyone who's interested in being a PA or going into PA school. So TAPA, that first one is the Texas Academy of PAs. They are the ones that kind of advocate for PAs here in Texas. So they actually form our PPACT, or our PA Political Action Committee. So like you talked about earlier, Crystal, with PAs being able to volunteer without a physician, that was actually legislation that they passed through our capital to kind of make sure that PAs could continue to volunteer without having to be tied down by a supervising physician. So they typically kind of send out polls and kind of take questions, and they'll kind of make legislation to kind of help increase our practice here in Texas. So Texas is a really great state to practice in. Our kind of local organization is really, really active in kind of pursuing and advocating for us as a profession. So they have student memberships. I would really recommend it because they also do conferences where they'll have PA students come or pre-PA students come, and you can kind of interact with practicing PAs. The other one is AAPA, or the American Academy of PAs. They do some of our credentialing, they kind of do some of the CME stuff, and they're a really great organization as well. They put on a lot of really big conferences. And then I personally am a part of our UT Southwestern alumni group, and then I also do this Guardian Angel project or program at my church. So part of being a PA, you always want to stay involved in your community, kind of reach out and advocate and educate other people about your profession. And that will help you and future PAs. So kind of something you always want to keep in mind moving forward. And then the last slide was just a fun aside that I put in. So our school was really big on PA Week. I know Crystal's talked about it. She also did the same thing. So as a PA student, you do stuff during this whole week. So it's October 6th to 12th. It's actually starts on the birthday of our founding, I guess, member, I don't know, Dr. Eugene Stead. So we start doing projects in the community. We kind of go out to schools, and we also show appreciation for any practicing PA. So if you're shadowing anybody, or if you're out and about and it's this week, our typical thing is that you'll actually get a payday candy bar and just tape over the Y, and then it just says PA Day. You can also do other stuff, but that's kind of what we did. And then this is actually one of the pictures, or one of the projects that we did to kind of raise awareness and try to get on our school website. Was we had our class shirts, and then we kind of stood in a PA formation with our banner. So we take a lot of pride in being a PA, learning about it, and kind of advocating for it. So that's something you can look forward to.
Awesome. Thank you so much for taking us through a day of your life. Now, it is our first Q&A section, and we have a lot of questions for both Tu and Crystal. The first one, I'll address it to Crystal and then ask Tu to also comment. Has there ever been a moment in your PA career where you felt you're not experienced enough for a specific patient's case? If so, how did you approach the situation? Did you work with other people part of your team, like nurses, nurse practitioners, so on and so forth? So, Crystal?
Yeah, totally. I don't claim to know it all, and I know I have a lot to learn. So there's always something that I have a question about, something I'm not certain about. So that's what's really nice about having a supervising physician, is that you have somebody who has this greater knowledge, who has a lot more schooling than you, who has a lot more experience a lot of the times than you. So you can go to them and lean on them for advice, like, hey, what would you do with this patient? Or, hey, this is what I plan to do with this patient. What do you think? Do you agree? Do you disagree? Do you have any advice? And sometimes it's not even medical issues. It can be just like a difficult patient in general to deal with, like personality wise or ethical wise or morally wise. I can go to them and say, hey, what would you do with this patient? This is, I don't know what to do. And so I think that's a really big thing in medicine. You need to go in knowing that you don't have all the answers. Even MDs, I think, at times can need to lean on others to help them out when they have questions.
And then Tu, would you say that your experience is similar?
Yeah, so I would totally agree. Usually every once in a while, I mean, that's pretty regular, like every month or so, I'll have a patient, either they're, not compliant, they won't follow up, or, it's something that's difficult in their case. I will most definitely reach out to my supervising physician. I think that's kind of the importance that I stress with really having a good relationship and kind of setting those guidelines early on, because she's pretty much open to me asking questions really at any time. I have access to all of her resources, all of her textbooks. And then if we don't know anything, then she has other MD friends that we can consult, which we do pretty regularly. So we'll consult with, maternal fetal medicine, or, cardiology or urology, depending, or even psych. We have a lot of psych patients as well, postpartum depression and all that fun stuff. So she is kind of like my just go to if I just cannot figure something out, I can't search, and I can't find anything that's helpful. I'll be able to kind of reach out to her. But definitely something that Crystal said was really important, is that we are pretty much lifelong learners. I think that's like a very key phrase that they always talk about in PA school, that you are pretty much going to be learning for the rest of your life. Sometimes doing all your CMEs feel like that too, but there's always like new information coming out, new things that we're learning. Even just through the process of making this PowerPoint, we've had information that we've had to update and kind of get, accurate information for.
Awesome. And another question we have for both Crystal and Tu is, how is the PA relationship with other members of a medical team, such as nurses, nurse practitioners, so on and so forth? So Crystal?
So I've worked with nurse practitioners, and I work with other PAs and MDs and DOs. And it really just depends on the people. I mean, the titles are just titles, I think. And if you are good at working on a team, then it's not going to be an issue. I really rely on my MAs a lot. In a lot of our private practices, we don't have RNs, we have MAs. And so I have a lot of respect for my MAs, especially the ones that have been in the field a long time. They've done a lot and they know their patients very well. And I lean on them a lot in a new clinic, especially because they know where everything's at.
Nice. And Tu, similar experiences?
Yeah, so I would say that for the most part, I think just kind of going into it with an open mind. I try to learn something from everybody. They taught us as a student that everyone is valuable, even, down to the janitor that's in the OR. So there's always something to be learned. So I try to, always be very open to talking to just a variety of providers. And so far, everyone has been really good. So, we deal with radiology, with other MDs, nurses. We have medical assistants in our office as well. A lot of our imaging techs or sonogram techs and things like that. And they've all been wonderful. So thankfully, I've been very blessed, I guess.
Well, that's great. That's fantastic that you guys are in a very open and collaborative environment. This next question is directed at Tu. Tu, would you mind sharing your experience working as an EMT and medical assistant? Which one would you recommend based on your personal experience?
Yeah, so I started my medical assistant job whenever I was in my sophomore year. I actually initially started as a receptionist and kind of just kept trying to do more to make it easier on the physicians. So I was like, well, I could learn to do this if it'll help you have a little bit more time. And so eventually they just kind of let me like kind of do vitals and kind of take do like the initial history or kind of confirming like the patient's past medical history. So that was nice because I got to do a lot of direct care. The pace was a little different. So there were times where it wasn't really crazy. So I could actually study or do work. So that was really, really nice. And so I really liked that. I think EMT is just a really good look into kind of ER and emergency medicine. And if that's something that you want to do, the schooling is definitely a little bit longer. I took like a summer semester, so it just took me a summer to do. But I really enjoyed it. I, saw a variety of patients. It was very interesting. I think it just kind of depends, because if you're not really good in like a high stress situation, being an EMT is not going to be for you. Because as as the way they kind of set it up, there's an EMT basic and then there's the paramedic. So during kind of more relaxed calls, basic life support calls, I would do them. And then anything that was more advanced, the paramedic would take care of that. And then I would actually be driving the ambulance with sirens on. And so it's kind of a different experience, but it was really, really cool. I really enjoyed it. And I think it just depends on the person. So if you want to kind of want a more relaxed environment, you want to still be able to get your work done, medical assistant may be for you. If you kind of want to get like a fast paced taste of what medicine is like, then EMT may be the one for you.
All right, awesome. Now this next question is directed at Crystal. On the topic of clinical experience during undergrad, can we have more information about being a medical scribe and how has that helped you in your career?
Yeah, so I actually didn't do any of my clinical experience until I graduated undergrad. So from undergraduate, when I graduated undergraduate and then applied to PA school was 4 years. So I had a lot of time in between where I was working as a scribe in the ED, and then I was also working as a scribe and a technician for an ophthalmologist. And so the ED scribe was really cool because it gave me a lot of experience in a high stress area, and I got to see a lot of variety of different medical issues. And then when I got to work at the ophthalmologist office, it was more of a specialty. So I got to learn the clinical setting. But it was a lot more hands-on patient experience because they utilized me as a tech also. So like I said, I had to pay through my way through school. So I worked jobs that paid better when I was in undergrad. And then once I graduated undergraduate, that's when I really buckled down and did my clinical experience.
All right, now this next question is for both of y'all. So did you have to get on you said you got trained as a general practitioner in PA school. Did you have to get on the job site training for your specialties? And I'll start it off with Crystal.
So in family med, I mean, that's what we're trained in. That's what we do as PAs. So I didn't have a lot of training going in. There's a little bit of a learning curve. I mean, the supervising physician wants to know how you work, wants to know what you know, where you're at kind of clinically. So there's a little bit of I would say like 3 months, you're kind of working really closely with your supervising physician until they kind of let you go on your own. And now I actually accepted a position at the psych emergency department. And so that's going to be a completely new field for me. And so I believe there's about 3 months of training that I'm going to be doing with them on the job.
Awesome. And then did you have any on-site training?
So women's health is kind of part of that primary care that we get trained on. So there were definitely a large portion of patients that I would see that I was pretty comfortable seeing. I think the main thing was just learning how my supervising physicians liked, patients to be managed, kind of things that they wanted me to notify them on. So I think to agree with Crystal, I kind of worked closer with them for about 3 months or so. They would kind of watch me, do pelvic exams, kind of do certain procedures. And then once they felt like they had a good understanding of how I practice, then they just kind of let me loose and just see patients on my own. But there definitely were more specific things that I had to learn. So a little bit more in depth, if the textbook treatment isn't working, kind of what are those next steps? What are those other things we could do? So I definitely learned those as I go. I still learn things today. So there's always some new patient case, some new disease pathology or disease process that I'm learning about. But overall, I think I would say maybe about 3 months working with them, kind of understanding my SP and how they wanted their practice to run and how I could fit in with that.
All right, now going off of what you said, and this is directed at both Crystal and Tu, what are some limitations that you experienced as a PA for caring for your patients? I will start it off with Crystal. Do you have any limitations for care?
So in family med, PAs are pretty autonomous. There's not a lot that we can't do. It just depends on your supervising physician, whatever they are comfortable with you doing, whatever they actually practice. I had one of my supervising physicians would not do any controlled substances. So that's like Xanax and pain medication. Even though I have my license, my DEA license to be able to prescribe those, that wasn't something he did in his practice. So I didn't do that in my practice. When I went to my new supervising physician, he did prescribe those kinds of medications. So then I was able to prescribe some of those for my patients. So it just depends.
What about you two?
I think, and I think I saw a couple of people ask about it in terms of like delivering. So I see patients throughout their pregnancy, you know, doing Dopplers to check heart tones. I kind of look over, you know, their non-stress test strips and things like that. But the kind of relationship that I had with my supervising physician before I started was that they wanted a provider to stay in the office. So that whenever they had to leave in the middle of the day, they would have someone that was able to kind of continue seeing patients and kind of take on their overflow. Same with their surgical day. So technically as a PA, you can deliver, and in certain work settings, you could be the one to deliver babies, but specifically for my relationship with my supervising physician, I don't. So a lot of times they do leave in the middle of the day or in the afternoon. And so I'll actually kind of absorb their patients into my clinic day so we can keep seeing people and we don't have to push any patients back. So I think that's one of the bigger questions about being an OB/GYN PA. But otherwise, you know, for the most part, I am pretty much able to kind of see my patients from start to finish. And there are some patients where they only see me. They have never met the MD. And so for the most part, I can kind of manage patients pretty well on my own, just with the kind of work relationship that I have.
Awesome. Now I'll do like one or two more questions and then we can continue on. What was the question? Hold on, it's fine. Is there upward mobility in the PA profession? Can you do teaching? Can you do research? Crystal, do you know?
Yeah, so all of my professors in PA school were PAs before they started teaching. So that's a big thing, teaching other PAs. And then they do research. They do a lot of clinical research, and then they also do research as far as student-wise, like PA profession-wise, what kind of programs are working, what isn't working. So yeah, you can definitely do teaching, get into academics. I do have I know personal experience. I have some friends that are like PA leads. So they are actually like in charge of doing PA scheduling, PA hiring, PA interviews for their clinic and their specialty. I think I saw some questions about like running a hospital. I haven't heard of any PAs actually running, like being CEOs of hospitals. I think that's more like an advanced healthcare degree or something. But really, yeah, PAs can go into fields other than medicine. So there's a lot of stuff out there. And if there isn't, you can make one.
Awesome. So the next question is directed towards two. When you have younger patients coming in for things like birth control, how do you deal with parents that come in with them and disagree about the treatment plan? And also, do you have another additional question off of that? Have you ever had a patient whose culture wouldn't allow them to have birth control?
Yes. So there are a fair number of patients who are younger who come in. So typically our youngest patients that we'll see are like 17, 18-year-olds. And there are a fair number that come in with their parents. For the most part, most of them actually come in and their parents are wanting them to be put on some form of birth control, typically more for like heavy cycles. Usually the parents are like really quick to say, no, they're not sexually active, but so there is a little bit of that dynamic, but for the most part, most patients that come in with their parents, the parents are already pretty open. And then I typically have a short time period where I actually will talk to the patient without their parent in the room. And I just kind of say that this is just part of our standard protocol, that there's just a couple questions I have to answer. I have to ask them just on their own if they don't mind stepping out. And for the most part, I haven't had any pushback on that. And you know, during that time period, I kind of get to talk a little bit more honestly about their actual sexual history and kind of what they're really wanting. So usually it's been pretty good to kind of work through that. I typically kind of discuss all the different options, side effects, things like that. And most of them are pretty receptive. There are a few patients that come in, whether it be for like heavy bleeding or irregular cycles, and certainly religious or cultural, they don't do any type of hormonal birth control. So unfortunately, there's not a ton of options for them. And it just kind of depends on where they are in their lifetime and kind of what they're expecting. And so that conversation is very patient specific. Sometimes all we can do is kind of watchful waiting, and I kind of check in on them, more regularly, and can kind of see how their symptoms are. And, sometimes it can improve. Sometimes it becomes bothersome enough that they're willing to kind of open up and try a birth control method that can help control their symptoms. So you're gonna have to work with some patients. Sometimes it just takes a little bit more follow-up. A lot of patients would kind of tell me, you know what, I want to do more research. I kind of want to read on this before I pick an option, and I give them all the reading material, all the pamphlets, everything they need that we go over, and then they call us, or we set a little reminder to call them in a couple months.
Awesome. Now, I love this conversation that I'm having with both of y'all, but I think people would really like to hear Crystal's day in the life of a family medicine PA. So, Crystal, can you take it away?
Sure. So we'll talk about what it's like to be a PA in family medicine. So really, it's taking care of everyone and really every problem. The quote is womb to tomb, because we can see newborns, we can see teenagers, mom and dads, grandparents, so everybody in between. There are some family med doctors that take care of pregnant patients, but the ones that I worked at haven't. We typically send them off to OBGYN and two. And then, I really like family med because you get to do a variety of different things. We're doing wellness visits. So patients who aren't sick, they're just coming in for physicals, sports exams, women exams. So we get to see that. But then patients who are sick, whether it's chronic illnesses like diabetes, or they're coming in with a cold or some minor fracture or some minor, injury that they got, we can treat that also. And then, any specialty that you're interested in, you're probably going to see it in family med, and sometimes in the same day. So I just put some examples of things that I've seen in the clinic. I've diagnosed patients with atrial fibrillation, which is a heart condition. I've diagnosed tuberculosis in my office before. I've seen so many rashes. And then, back pain is a big one. Psychiatry is a big one that we see almost every day. So anything that you can think of, we've probably seen it. Not that I've treated it. I've probably sent them out to a specialist, but I've at least recognized it and been able to diagnose it and get them to the right people. But some of my favorite parts of working in family medicine is the holistic approach to medicine. So we're kind of taking care of everything. We're taking care of, we're really interested in their social life. We want to be able to prevent disease. So we're really getting to know the patient. Where do they work? Where do they live? What do they do? Where do they eat? And so that it also builds like a sense of community, because you want to know, who are they living with? What are their relationships like? And then we're also interested, in preventative healthcare and public healthcare. So that's also, worrying about the community. So I really like that. And then, like I said, building relationships. Sometimes I see mom and dad come in together. Sometimes I see mom come in with her kids, and I'll see the kids, and then next week I see mom. Or I'll have, an adult patient bring in their elderly parent, and I know both of them, or I know they live together, or I know one of them was sick last week, so I want to check on the other one. So that's kind of cool that you get to see the entire family and get to know everything that's going on there. And then in family medicine, it's a really nice clinic setting. It's most of us are Monday through Friday, 8 to 5, typical 8-hour shifts. You may have to work a Saturday. I do one Saturday a month, so it's not bad at all. And then you may or may not have to take call. It just depends on what your supervising physician requests. So there was 4 of us in our office, and we would rotate taking call. So that means once every 4 weeks, I was on call. But being on call in family medicine is super laid back, super easy. You're not going to have somebody wake up in the middle of the night and say, hey, I'm having a heart attack, I need your help. I mean, you might, but rarely has that happened. It's mostly like, hey, I didn't get my medication sent yesterday and the clinic's closed. Can you send it in? So it's very, very chill, very laid back in that sense. So I like that. But what my typical day is like, I usually get to the office around 7:30 or 8, depending on the day. I'll get in, I'll have breakfast, I'll have coffee. I check in with my staff, check in with the MAs, just kind of make sure, see what the vibe's like, see if they need anything, see what's going on in their life. And then I'll get to my desk and I'll start checking messages. I'll get messages from my supervising physician or from billing that I didn't close something, or I'm reviewing labs or imaging results that I ordered. So these are like tests and images that I've ordered on a patient on a previous day. So unlike in the emergency room where you get stuff back right away, in Family Med, we've got to wait a day or two before we get any results. And so as those come in, I'm really reviewing them, looking them over, making sure there's nothing that needs to be addressed right away. And if there is, I'll call the patient or I'll have them come in to discuss. And then I'm just making sure that we've got everything on board as far as if there's a procedure coming in that I know I'm going to do, make sure we have all the supplies, make sure that those lab results for that patient coming in are actually in for review before they come into the office. So that's just kind of planning ahead. And then we start seeing patients at around 8:15-ish. So typically I'll have about 20 to 25 patients depending on the day, and it'll be a mix of follow-ups, it'll be new patients, it'll be some just wellness visits. And then we leave room for walk-ins because people don't make appointments. They don't like to make appointments. They just like to walk in. So you always want to leave room for that. And then to start my day, the MA usually will bring the patients back. They'll check their vitals. They'll get the reason they're there, and then they stick them in a room for me. And then I'm seeing patients back to back until lunchtime. And in that time, I'm also answering some phone calls from other providers or from patients that call in. And then, we have drug reps that come in that I need to say hello to. I sign off and get samples from them, or they bring us lunch. So you got to be nice to them. And then after lunch, it's back to kind of doing the same thing when I first got to work, checking messages, reviewing labs, catching up on any charts that I didn't finish from the morning. And then I'm usually done by like 5:30. So it's pretty nice and easy schedule. So let me show you what it's like to actually see a patient in family medicine. And so these aren't really, possibly it's a patient that I've seen, but really I wanted to just give you a general idea of what you're going to be seeing in family med. Like I said, we take care of everyone and everything. So this lady is a really good example of that. This is a 57-year-old female with fatigue. And once you get into medicine, there are certain chief complaints that'll come up that you'll just be like, oh, man, because it's a lot of work coming up. So because fatigue could be anything, right? There can be so many things that can make this woman fatigued. So we get some more information from her. We start taking an HPI, so the history of the present illness. We need to know what else is going on. And I need to figure out, why is she fatigued? Because there could be so many things. So I'm already starting to create a problem list in my head of what this could possibly be. Is she tired from staying up all night? What's going on? So 57-year-old female presents to the office for the first time with complaint of fatigue for 3 months. She reports little to no energy for daily activities. She's noticed increased frequency in urination, waking up in the middle of the night to go to the bathroom. She thinks it may be due to her increased fluid intake because she feels thirsty all the time. In the last week, she noted urination to be more frequent and burning with urination. So many things already going on. She's fatigued, she's got frequent urination, increased thirst, burning with urination. So I'm starting to think, okay, what could be going on? Is this a thyroid issue? Like Tu said, that's one of the most common hormonal imbalances. And that can make you really tired. Does she have an infection? Because now she's burning when she pees, so that could be a sign of infection. Does she just have an overactive bladder, which is common at this age? And she's tired because she's going to the bathroom every night. The other thing you want to consider is diabetes. She's got 2 out of the 3 P's for diabetes. Polyuria, so increased urination, and polydipsia. She's got increased thirst. And then the third being polyphagia, which is increased hunger. Or does she have an adrenal disorder? So already we're starting to come up with our differential diagnosis before we've even gotten any, past medical history, before we've even done an exam. We're already starting to think what's going on with this woman, and try to, start thinking of what I want to do for her. So then we get our history, which is the most important thing you're going to do in medicine, is getting a medical history, because like I said, there's so many things that could be coming that could cause fatigue. So with this medical history, we're looking for things that can help explain her current symptoms, But in family med, we're also looking for risk factors. You know, I want to know what's going on with this patient's daily life, because we're not only trying to, you know, solve her current problem, we're trying to prevent and help her understand her own illness and manage illnesses, and really just help them set healthy goals. We want to improve the overall health of this woman's life. So how can I optimize this patient's health is really what you're looking at for the medical history, along with what's going on with her. So her past medical history, we find out she's got some acid reflux, no allergies. She's taking omeprazole, which is a medication for heartburn. She's got no surgeries. But if you look at her family history, there's a lot of diabetes going on, some hypertension going on, and then one of her aunts died of breast cancer. So all those things are good to know. And then in her social history, we see that she's also a smoker, and she doesn't do very much exercise, and she drinks a lot of soda. So we've already got some more things to add to our problem list. So along with the fatigue, urination, and increased thirst, she's also got acid reflux, she's got tobacco abuse, and a poor diet. So then we go on to the health maintenance, which is also part of the medical history. So in the health maintenance is where we're looking for risk factors. Again, we're family med, so we got to talk about preventative healthcare things. So we're looking at screenings for colorectal cancer, screenings for breast cancer, screenings for cervical cancer. And so for this lady at 57 years old, she should have had a pap smear, a mammogram, a colon cancer screening, and then she should have her vaccinations up to date. And looking at her health maintenance, everything's up to date except for her pap smear. That was done 5 years ago, and it should be every 3 years. So she's a little late on that. But mammogram and cancer screenings, those are both good. And then we go to her review of systems. So in your review of systems, you're really asking questions that are going to help us develop a diagnosis. So you're looking for, you're asking the patient questions about other systems besides what she gave us in the history of present illness. The things that maybe she thought weren't important to bring up at this visit, but they could help you develop your a differential diagnosis. So at her review of systems, really the only thing, the additional information we learn is that she's got a 10-pound weight gain. She's got some blurry vision, some headaches, and let's see what else. She's got some heartburn, which she told us about. And then she mentioned she's also got some vaginal discharge and vaginal itching. So she didn't talk about that when she first came in, but upon further questioning, we do find that out. So we're going to have to do a pelvic exam on her. And so now your problem list is growing even more, right? So now she's got some weight gain, now she's got some blurry vision, headaches, vaginal discharge, vaginal itching. So you're adding to that problem list that you had in your head, and you're starting to develop, okay, what am I going to start looking for? How am I going to test this patient? What else can we do? So then we go to our physical exam. And then you look at your vitals here. That'll be the first thing. Oh, you can go to the next one too. And so at her vital signs there at the top, that everything looks pretty normal except for her blood pressure. So her blood pressure is at 147/92. Normal should be less than 120/80. And so we're going to want to address that blood pressure, either recheck it and see if it goes down, or that's going to be another problem we add to our differential diagnosis list, is high blood pressure. And then her weight gain, she's at 192 pounds and her BMI is at 33. And so a normal BMI or a healthy BMI should be less than 25. And so she's technically in the obesity range. So add that to your problem list also. So before we even touch this patient, we've got like 10, 11 things that we need to address. So already we're getting a little overwhelmed, but it's okay. And then you do your physical exam on her. Everything looks okay, except we find that she's got some white macerated lesions between her toes. So that just means she's got some skin breakdown going on between her toes, which most likely is signs of a fungal infection. So another problem we have to address. So once we're done with the physical exam, we're going to look at review our problem list. And she came in for fatigue and frequent urination, and we end up with 11 different problems. So how the heck do we address all of this in a 20-minute visit? That's family med. You start asking questions and you uncover a lot of different things. But the cool thing is, you've been developing your plan, and since she started talking at the very beginning, you've got a list of things that it could be after you asked your review of systems. You've kind of narrowed some things down. Like I said, she had 2 out of the 3 Ps for diabetes. You add that with her fatigue, the blurry vision, and now some fungal infections. Those are all pointing to signs of high blood sugar, so you're definitely going to want to check her high blood sugar. And then some things that aren't as pressing, you know, she was due for a pap smear. We're family med, we can do a pap smear. We're not going to address that today because that's not very high on our list of all these other things she's got going on with the vaginitis, the high blood pressure, the tobacco abuse. So we've already got some things to address. This is a patient you're probably going to bring back anyways, so that pap smear can be done at a later date. So in family med, we're doing everything, but you don't have to do everything at once. You're really just kind of doing what's most important right away. And so then finally, our assessment and plan. Fatigue, we don't know exactly what's going on, but we have some ideas, so we need to do a workup. We're thinking it might be due to her high blood sugar. How do I know that? Well, because I asked for a finger stick in office. So my MA goes, she sticks the finger of the patient, gets some blood, we check her blood sugar. It's 225. That's pretty high, should be less than 120. So this lady has high blood sugar, so I want to address that even further. So we're going to get some blood from her, and we're going to look for a hemoglobin A1C, which is an average of the blood sugar for the past 3 months. So that's really going to help us assess for diabetes. And then we're going to give her some diet and lifestyle recommendations. You know, tell her to cut back on the sodas, do a little bit more walking, watch what she's eating. And that's really going to help the blood sugar. And then, you know, the elevated blood pressure. So she came in, she had a high blood pressure. We rechecked it. It was still high. So technically, we can't diagnose her with hypertension until we have another high blood pressure reading on a second visit. But what we can do is look for other things that could be contributing to the high blood pressure. Does she have some kind of adrenal issue? Does she have some kind of kidney issue that's making her blood pressure go high? So we're going to get a comprehensive metabolic panel, which is going to help us look at some electrolytes and her kidney function. And then we're also going to get a cholesterol panel because we want to see what's her risk factor, right? Like if she's got high blood pressure, she could be at risk for a stroke or having a heart attack. So we want to see how much is her risk. And the cholesterol panel helps us determine that. And then also I want to get an EKG. I want to look at her heart because if she's had this high blood pressure for a long time, plus the high blood sugar, I want to check it on her heart and make sure it's okay. So we get an EKG to look for any kind of end organ damage. And again, the lifestyle dietary recommendations. We got to tell her to stop smoking. So that's actually on my list too, tobacco abuse. That is something you do get paid for as a provider, is giving counseling for tobacco abuse. So as long as you document it and you actually counsel the patient on smoking, you can bill for that. So that's important to put on there. And then she has cystitis, which is a bladder infection. We found that out because the frequent urination, the burning with urination, kind of had a suspicion she was going to have a urinary tract infection. So I asked for a urinalysis, which is done in office. They check her urine. Turns out she's got some white blood cells in it and some nitrates, which points to a sign of infection. So she's going to go home with antibiotics for that. And then when we did the pelvic exam to assess that vaginal discharge, we took a sample of that discharge. We looked at it under a microscope and found out there was some yeast. And so she's going to go home with the prescription to treat that yeast infection. And then the tinea pedis, so fungal infection on her feet. We want to treat that also. We're going to give her some antifungal cream and send her on her way. And then address her acid reflux. Omeprazole is a very fine medication for that, so she can continue taking that. And then the obesity, again, education and diet. That's a big thing we do in family med, is just educate, and counsel the patient. So anytime you see a high risk factor for something, go ahead and address it. So then you get your labs on this patient. You order them, and then you don't get them back for a couple days. But when you do get them back, come in the next 2 days and you look at her labs. And so here they have the normal values on the right and the patient's values right in the middle. And I put the ones in red that were abnormal. So like we suspected, her blood sugar is high. So the hemoglobin A1C is 8.9. To be diagnosed for diabetes, it's got to be 6.5 or higher. So she definitely has diabetes. And she's probably on the border for needing insulin. So that's something I'm going to have her come back in so we can address and talk about treatment options. Her cholesterol is also high. So you look at total cholesterol, LDLs, HDLs, and triglycerides. The HDLs are actually low. We actually want that higher because that does give you some protection against the bad cholesterol, which is the LDL. So what we're really concerned about here is the LDLs, which is the bad cholesterol. For somebody who's got diabetes, we want that less than 100. So again, she's going to need to come in and discuss treatment options for that. We see her electrolytes are normal, so that's her potassium or sodium. Those are normal, and her kidney function looks good. So, and her EKG was normal. So all of that to say, her high blood pressure is probably just your run-of-the-mill normal high blood pressure. And so for somebody who's got diabetes, that's uncomplicated, we are going to have her come in for treatment with the goal of getting that blood pressure down to about 130/80. And then we want to follow up with her regularly, because this is somebody who's going to want to be followed until those numbers come down to normal. And then she's going to need a lot of education, because this is probably the first time she's been told she's got diabetes or high cholesterol, and she's not going to know how to manage that. So that's your job to do that also. So a lot of things on this patient, but that's your typical family med patient, somebody who's come in with one tiny complaint, and then you start to unravel the onion, and there's so many other things to address. But it's fun. I really liked it. And the other thing to consider, though, that I should say, is this woman has health insurance. So we were able to order all these tests and do all these things for her. Sometimes you get this exact same patient with more problems sometimes, and they don't have health insurance. And that's we could do a whole nother lecture on that. But that's that patient. So that's patient case study 1. So we'll go to somebody a little younger. This is our 19-year-old male with poor concentration. So like Rachel said this earlier, I'm interested in behavioral health. So I wanted to pick a behavioral health patient. So this 19-year-old male reports he's unable to focus and concentrate on his work at SMU. That's a college here in Dallas. He's been studying English. He reports being on academic probation due to poor grades. He states he's never been tested for ADHD and performed well in high school, but since starting college has found it more difficult to concentrate due to intense schoolwork. Patient mentions he was told by a friend if he got a prescription for Adderall, his scores would go up and he would be off academic probation. So this is a patient that you probably saw him for his physical when he was like 15. But so there's a couple of red flags that that you're getting on this case already. Anytime a patient comes in asking for a medication by name, especially a controlled substance, like Adderall or Xanax or hydrocodone, your antennas want to go up. Patients don't typically know the names of their medications that they're taking, and so when they're asking for one specifically, you want to delve in a little bit more. The other thing to notice is he's 19, he's in college. We know that Adderall has abuse potential, so we want to ask him about substance abuse issues. Even if he is taking this Adderall for substance abuse or for fun, we want to ask about other substances he could be abusing. That's a really big risk factor there. So start developing our differential diagnosis. Maybe he does have ADHD, but typically those symptoms are present before the age of 12. So starting to show at age 19 as somebody who's made it all the way through high school without being tested is highly unlikely, but possible. Other things I'd like to consider is depression, anxiety, some kind of mental health issue. He's going through a big life transition, going to college. So, that could be some early signs of depression. And then the substance abuse. So you really want to ask him specifically, has he ever tried that Adderall from his friend? That can help kind of open the door and ask about other substances like alcohol or marijuana or any other drugs that he may have tried. So that'll get us to our medical history. And then, we find out that he doesn't have any past psychiatric history. That's important to ask because patients with that's been previously diagnosed with psychiatric disorders, they can present at high stress situations like going to college. So no history of mental health issues, no substance abuse issues in the past either. He's not taking any medications. So, medications are another thing you want to ask. Those could cause side effects. So you always want to get a really good history. Even though he's 19 and healthy, you always want to ask. And then family history is important here too, because if there's any family history of psychiatric disorders, those could be genetic. So you want to ask about mom, dad, brother, sister. And he doesn't have any of that. And then the social history is really important for this patient also, because like I said, family med is also really interested in community health and public health. So we want to make sure he's taking care of himself while he's in college. So things like sexual activity is a really big thing you want to ask about. How many partners does he have? Does he have sex with men or women or both? Is he using protection? So these are really important things to keep in mind. And he actually does have some risk factors. So he smokes. He actually vapes 2 to 3 times a day for the last 2 years. He's drinking 3 to 4 beers a day. He's only 19, so that's kind of a red flag. He reports marijuana use occasionally. Caffeine, he's drinking 2 to 3 cups of coffee a day. He is having sex with multiple male partners. Little bit of exercise in the past, but nothing now. And then he eats out most days, so his diet's kind of crap. So, there's a lot of counseling that can happen for this patient. So then we'll go to his health maintenance. And health maintenance varies by, the preventative health measures that we take are going to vary for age, right? So that lady was 57 years old, so she had to be screened for all these cancers. At 19, one of the things we really worry about is HPV. So HPV is the human papillomavirus, and now there's a vaccine for it. So everybody should have had that by the time they were 9 or 11 is usually when we start. But the age range now is, 9 to 26. But actually, I think it just recently got extended to 45 years old. So if you've never been vaccinated for HPV, you can get it up to age 45. And so that's really important because he's got some risky sexual behavior, right? He's got multiple partners. He has sex with men. And that is high risk for HPV. So you really want to ask him about that. And luckily for him, it's up to date. And then also ask about HIV. And he has been screened, and that's negative. And then again, the review of systems. We're looking at asking for questions that could help us with our diagnosis. We want to rule in or rule out anything. So with the review of systems in this patient, you're going to do more psych stuff. So you're screening more for depression, asking about psychosis, anxiety, OCD. Is he hallucinating? Is he hearing voices? Is he paranoid? Is he having any kind of depressed mood? He does admit to having a depressed mood. He is sleeping more, 10 hours, which is kind of a lot, but he's 19, so decreased motivation. He reports decreased energy, irritable, he's got low self-esteem. But luckily he denies suicidal ideations, no hallucinations, and no paranoia. So those are all good signs. And then we go to his physical exam. And in his physical exam, things look pretty good. Vitals are stable. And then really in psych, when you're doing a psych assessment, most of it's going to be observational. So you want to get a really good look at the patient. So the physical exam doesn't include just putting your hands on the patient. It's watching them, looking at them. What is their appearance like? Are they well groomed? Have they taken a bath? Have they shaved? Are they dressed kind of crazy? Do they have crazy colors on? Is their hair all over the place? So these things can kind of give you an idea of what's going on inside the patient's mind. And then you look at their speech. Are they talking clearly? Are they talking gibberish? Do they look like they're talking to somebody else? Do they look like they're listening to somebody in their head? And then specifically, you want to just ask them, are you having any kind of suicidal ideations? That's really, really huge, just making sure that they don't have any thoughts of suicide, previous suicide attempts, or a plan for suicide. So, the problem list at this point now, I would say he's got poor concentration, he's got some tobacco abuse, he's got alcohol use disorder, he's got some drug use, he's got high-risk sexual behavior, he had a little bit of weight loss, depressed mood, hypersomnia, decreased motivation. So again, you come in with one problem and you end up walking out with a bunch more. So lots of counseling for this patient, but I think looking at the whole picture like this, once you get your history, it's kind of obvious to me that this patient is going through more of a depressive episode versus having ADHD. So that would be something I really would want to assess is the depression. And then you want to counsel the patient about, drug abuse. You want to counsel the patient about his risky sexual behavior. And then you want to kind of educate the patient. He came in thinking maybe he was having ADHD because a friend told him. So you want to let him know that that's more of an inattentive, hyperactive diagnosis, and that's usually seen before the age of 12, whereas depression can come on at any age, and especially in stressful life situations. And so for him in the assessment and plan, We really want to address the depression. I give him a PHQ-9, which is a screening for depression, and he scores a 16, which gives us a moderately severe depression. So that's pretty high. This guy's at high risk. I would send him to a therapist, definitely, because that's first line. But then I'd also want to talk to him about some options for medication to treat his depression. And then again, discussing the substance abuse, tobacco use, marijuana use, and the alcohol abuse. All of those could also be contributing to his symptoms. And especially if we're going to start him on an antidepressant medication, alcohol and marijuana abuse could make those medications less effective. So those are things you're definitely going to want to counsel him on. And then the high-risk sexual behavior, that's part of family med, is the public health and the community health aspect, is keeping the community safe. If he's going around spreading gonorrhea and chlamydia, you know, that's not a good thing. So you want to definitely educate him on that. And then one thing that I didn't put on here, but I should mention, if he is a male that has sex with males, then one of the things now that we're offering is PrEP for HIV. So if he has a high-risk sexual behavior, he's not using protection, then PrEP, which is a medication to help prevent getting HIV, that could be offered to him as well. So you got to be comfortable asking these questions, because in family med, that's part of your job. And that is that guy.
Sorry, Crystal, can I just kind of interrupt
Oh,
you?
yeah.
In that very last comment, so you'd also talked about HPV. This is actually something I think that just happened this week. That would also go into the high risk behavior. So the HPV vaccine is actually now also, I think, CDC approved to protect against head and neck cancer. So HPV, with changing sexual practices, we see HPV in different locations than we used to. And so getting the HPV vaccine before 26 is the most effective, just because at that point, you're not as sexually active, so you haven't been exposed to as many of these strains. Even if you have been sexually active before, there's still some benefit from protection to the strains that you have not come in contact with. So it's the Gardasil 9, so it's those 9 strains. But if you haven't had it done, I would definitely recommend it to anyone that's watching.
I think that's, yeah, thank you for bringing that up too, because speaking of getting, you know, cancer in new places, we're also well, I haven't, but I know at the free clinic, they offer pap smear, anal pap smears for men who have sex with men to check for HPV or cancer cells that are caused by HPV. So good point. Thanks too.
Yeah.
All right, before we move on to the Q&A section, can we get some advice from both Tu and Crystal? So if you went back in time, would you still choose PA first, Tu?
So yes, I would still choose PA. I really enjoy medicine. I enjoy taking care of patients. I like the kind of focus that I get to have on patient care versus kind of getting caught up in some of the weeds with a more admin side that you may have to deal with as an MD managing your own practice. So I really enjoyed it. I think that PA school was probably the hardest thing I've ever done. It took a lot out of me, but I think just seeing the way that you're prepared for practice afterwards really makes it worth it. I think the main thing for counseling or kind of just advice for anyone going into medicine is just to remember that you are going to be a person who has a direct impact in a patient's life. So whether they do well, whether, you know, there are good health outcomes, it is kind of based on the actions and the things that you do in clinic. So it's not something to kind of just take lightly. It's something that some days I go home and I'm praying for a patient. I don't know if I did enough, or I don't know if they understood my message. And there's always patients that I kind of worry about. So just kind of keep that in mind as you move forward. It's definitely a lot of responsibility.
All right, Crystal, what about you? Would you still choose PA? Is there anything you would do different?
No, I love being a PA. It is like the best of both worlds. I get to practice medicine, but I don't have quite all the responsibilities that an MDDO has. So it's kind of nice. And then, you know, I feel like I always have somebody who has my back. So I really like that. So yeah, no, I would not choose another field to go into. I wouldn't choose another specialty. I would or actually specialty, but I should say another, like I wouldn't go MD or DO. I've got patients who ask me, oh, are you going to go back to medical school and become a doctor? No, why would I do that?
So a frequent question that I'm sure a lot of members that are still watching have, how has COVID affected both y'all's career, and do you see this being any change to medicine? First, let me ask Tu to answer.
Yeah, so there was a time period whenever we actually had to kind of really decrease the number of patients we saw in the clinic. We were only seeing the OB patients that we absolutely had to, and then we had to kind of reschedule everyone else. And then kind of in mid-May, we were able to start seeing patients again. So then we had like a huge influx, but we've changed the way we schedule patients to kind of space them out. Certainly our kind of cleaning procedure, all our patients have to wear masks. They have a screening questionnaire that they do. We wear masks and face shields as well. That way we can kind of protect each other. And any patients that have test positive, which in the past month or so, we've actually had an increase in that, we have to see a negative result after 2 weeks. They have to go back and they have to show us those results in order for us to see them in clinic. Sometimes we'll do like a televisit to kind of bridge that. I think that's been the biggest change. We've done more televisits and telehealth during this pandemic. So I think that's something new. I definitely don't think it's gonna be anything that would replace the traditional in-office visits, because there's so many things that you're missing out on. But I think that's definitely something that we'll probably kind of see integrated more into practice.
All right. Crystal, what do you think?
I'm sorry, what was the question? I was reading all these comments in the chat.
You're good. So how do you think this pandemic has affected medicine? How has it affected your fields? And also, do you see medicine kind of changing because of COVID?
So I got furloughed from my job actually in family med. So we were a small practice. And so we just weren't prepared to handle this pandemic. And so I'm actually on furlough since March. So two things out of that. One, I am really lucky that I have a supervising physician that was very understanding and kind of kept me on until things, what we thought were going to calm down, but actually haven't. But in this time, I've actually been able to explore other options. And like I said, I've been in family med for 3 years, and I feel like this time has really given me an opportunity to explore other fields. And like I said, I've always been interested in studying the brain, and my degrees in neurobiology. So I actually started looking for a job in psychiatry, mostly because I wanted to do telemedicine in the beginning, because I feel like that's where we were headed with the whole pandemic. But it's actually a lot harder to get into telemedicine if your practice isn't already doing it, is what I've come to realize. And then by chance, I applied at one of the hospitals here and got the psych ED job. So I was able to actually transition specialties during this pandemic despite being furloughed.
Awesome. So I know y'all both mentioned being married. How do you balance relationship and career? And I'm gonna start the question off again with Tu.
Yeah, so like I mentioned earlier, I actually met my now husband during didactic year PA school. So I met him, not in school. So there was certainly time to kind of date. I think he kind of understood the demands of PA school because that's where he met me in that time in my life. So we had to do a lot of kind of different dates, so like study dates where I'd be studying and he'd be kind of around me-ish. And that would count as our quality time. So I think as he kind of got used to seeing what my schedule was like, kind of the time requirements that I needed in our working life, we're able to kind of set apart time to kind of really have our just us time where we're not working, we're not doing anything else. And then we have time at home where we can do other things. So I think that's been really helpful. So finding someone who really understands that PA school and even medical school, whatever health profession school you go to, it's going to take a lot of your time. And they have to be okay with just kind of being a supporting role, knowing that you're going to kind of be almost like an absent partner for a short time period. So I think that was really, really helpful. I know that a lot of it is just time management. technically in school, there's always something you can study, always something you can do and learn. It's just kind of figuring out what schedule works best for you and kind of sticking to that time. We had classmates that planned weddings during school. We had people that got pregnant, just like I was saying. We had parents that were in class with us. So you can certainly do it. It's just really figuring out time management.
Rachel, this is Fowler. I have a comment. Are y'all still there? Hello?
Yeah.
Okay. I wasn't sure. I just was making sure that the working group was not snoring too loud. Just kidding. I worked with a PA for years. I've worked side by side with them from my entire career. But when I worked directly with a PA that worked in my practice back in Georgia, one of the things that I found was that we became very much of like mind, similar physical exams. It was emergency medicine I was doing. So, we were assessing, sometimes quite sick people. And what I found was that over time, because we had to grow together, right? Over time, we thought alike. And I learned from her and she learned from me. And I thought that we had a very close working relationship. So and then Crystal, would you say that you've learned a great deal from the physicians with whom you've worked? And have you felt that partnership?
Start, Crystal.
Yeah, I've learned so much from my supervising physicians. Actually, I mean, that was a big reason why I wanted to be a PA, was because I knew I was going to have a mentor in a sense going into practicing medicine. And like Tu said, we're lifelong learners. And so I'm always leaning on my supervising physicians to teach me something new, even if it doesn't regard a specific patient. If they know something or they learn something, I'm always asking them to share it with me. So yeah, and then just seeing how they are as providers, how they practice, how they approach the patient, how they talk to the patient, how they deal with certain tense situations with the patient. That's really been a big help for me, because sometimes that's not things that you learn in school. That comes with practice. And so I've definitely learned a lot from my supervising physician.
Yeah, I would agree with that. I think having that kind of guidance early on, I am constantly kind of picking the brain of my supervising physician after work. If I see that they've had an interesting case, I kind of follow up and see kind of the reasoning behind their treatment plan. So it's been a really great experience. I think I've been very lucky that my supervising physician and I kind of get along. So she's been very open to questions. So I've had a chance to learn a lot.
The greatest person that could sew skin together, it's not a seamstress or seamster in medicine, I guess, but was the PA with whom I worked. She taught me how to sew with 7-O-ethyl on an eyelid. And I have to say that it was just a very remarkable experience. And it affected my life for the next 2 generations that I've been a physician. It's approaching the end of the second hour. This has been an astonishing meeting. I just loved it. The questions have poured out. Everybody go in and say thank you on the Zoom chat while I point out a couple of things. And I want you 2 ladies to watch the Zoom chat and watch all these thank yous come pouring in. Y'all, you broke the record. We had 1,600 live people listening to you tonight. So it was a record that beat by 300 our last one. So I don't know when was the last time you addressed 1,600 people live, but you sure did tonight. We were just so amazed and grateful for this wonderful presentation. It was so calm and reasoning. It's the epitome of what patients need to hear, which is caring professionals who take the time to listen. So 2 parting words from you.
Yes. So thank you for having me here. I kind of enjoyed working on the presentation. I think any last advice I would have is, if you're interested, PA, medicine, whatever, start as early as you can with patient education. Look at what applications need you to write down, make an Excel, start documenting really early, because I'll ask you for everything. And then don't be worried if you're not following the traditional path. So I was a science major, but we had teachers, we had accountants, we had music majors. So just know, like Crystal said, if life takes you a different way, you can always find your way back, to this next purpose or this new purpose. So don't feel pressured to kind of follow the standard mold.
And Crystal, any closing thoughts from you?
I would just say, well, one, thank you for having me, and thank you to everybody that got on and listened to me. And two, that was really cool. But I would say don't be afraid to reach out. Whether it's reaching out for a letter of recommendation, reaching out to Shadow, reaching out for advice, reaching out just when you need help mentally, when you're struggling, just don't be afraid to reach out. I know that was something that held me back for so long. So just don't be afraid to do it. Just the worst that somebody can tell you is no, and that's not that big of a deal.
And Rachel, Madam Chairman, would you like to wrap this session up?
Thank you all for joining us today. I'm sure all of y'all are wondering about the quiz information. So if my internet could show, yes, here's the quiz. You have to manually insert the pin with the dashes into the assessment information. You do not need an account, a Quest-based account, to do the quiz. The password is CASPA in all caps, and you have until this Friday to do all the questions. You only get 2 attempts, so please try your best. And that's all I have. Do we want to go into any more questions for the people that are still here? Or I'm sure there's a lot of questions that still people are wanting to ask.
Rachel, we will have the recording of this session, and we will have all of that posted up on the website very shortly. The pin and the password to the Quest base is already on the website now.
Okay. Well, do we want to do more questions or?
All right, everyone. Thank you for your wonderful time. This has just been a tremendous session. We broke all records. To our ladies of the evening, thank you so much for coming. We appreciate it very much. And we wish you all the best. And to all of you, please have a wonderful evening. Good night.
Thank you.